stem cells so that during the second phase we can give high-dose chemotherapy and stem cell rescue. Now in North America, the standard is tandem transplant, but in Europe it is still single transplant. I don't think you'll be asked that on the boards, but just knowing that this is an aspect of disease, and that all children receive radiation therapy to the primary site of the tumor. And then finally, there's an important part of treating minimal residual disease using biologic response modifiers, isotretinoin, and anti-GD2 immunotherapy. There have been randomized clinical trials that have shown the benefit of both isotretinoin and also immunotherapy, and so I'm sure that those are questions that could easily be asked on the boards. Role of surgery, just to summarize, is biopsy to confirm diagnosis and biologic features, except in infants with L1 tumors where you may consider watching. Primary resection to achieve at least 50% of tumor resection in lower intermediate risk, and then complete tumor resection in those children with high-risk disease, obviously always attempting to spare organs. And radiation role is very limited in low and intermediate risk disease, but as I stated, is mandatory for all high-risk disease to prevent local recurrence. And then I added this table if when you're studying the night before the boards and you really want just one last quick reminder of what the treatment strategies are for the different risk groups in neuroblastoma. And then finally, just a quick note on response. The initial international response criteria was published in 1993 and used categories of complete remission, very good partial remission, mixed response, no response, and progressive disease. As you can see from this really relied on technetium bone scans and didn't really quantitate bone marrow disease, but this has been used in all clinical trials up until the last 2 years. The international community published a revision of this that will be used moving forward, and I'm not sure whether this will be included in the boards or not, but it basically brings in quantification of marrow disease and the use of MIBG scans to quantify metastatic bone disease so that you have a primary tumor, a bone response, and a bone marrow response, and all three of those come together to make the overall response. The differences are that VMA and HVA are no longer used. MIBG or PET are used in all of the evaluations. Bone marrow is used with a semi-quantification response assessment. And the categories of VGPR and mixed response are no longer used, but minor response has been added to take into account sometimes primary tumor can become calcified and not change in size when you have metastatic response. I won't go through the specifics, but I put it all there for you for your own reference should you have patients and you're looking at an easy way to evaluate response and each of the categories, including primary tumor, metastatic, and bone marrow. Okay. Last, for neuroblastic tumors, complications are from surgery for organ removal or neuronal damage, radiation, chemotherapy, most importantly, ototoxicity from the high doses of platinum agents that we use, and infertility from the high doses of alkylator, and risk for secondary malignancies. Biologic therapy, we now know that isotretinoin causes decreased bone density, and that is a question that might be asked on the boards. Okay. Moving forward, pheochromocytoma and paraganglioma. Again, this can be a very complex topic, so there are slides in here to help you kind of remember different aspects of this tumor. This is an extremely rare tumor, so I can't imagine you're going to have a ton of questions on this, but I'll try to highlight some features that might be important. These are neuroendocrine tumors that are arising from chromaffin cells of the sympathetic tissue in adrenal or extraadrenal sites, so sympathetic pheochromocytoma or parasympathetic tissue. And those parasympathetic tissue tumors are generally in the thorax and the head and neck. So two categories, sympathetic and parasympathetic. The sympathetic generally are the ones that we think about secreting norepinephrine and epinephrine and their metabolites. It's important to know that the majority of these tumors are considered benign, with 10 or 25% respectively being considered malignant. However, in children, it is much more common to have a malignant phenotype of pheochromocytoma or paraganglioma. Again, there are molecular subtypes, and I just have these here because of interest. They help potentially guide therapeutic options with molecularly based therapies in this disease. And then again, biochemical phenotypes where you have those tumors that secrete certain byproducts of adrenaline, so the noradrenergic, the adrenergic, and the dopaminergic. And again, these are important primarily because they are each associated with specific germline mutations that may put patients at risk for developing these tumors. Okay, as I said, this is an extremely rare tumor. About 40% of the cases are known to be associated with germline mutations, but in pediatric patients, that may be as high as 80%. So if you're going to have a question about this disease, it's most likely going to be on association with germline abnormalities. So in pediatric patients, it's really recommended now that all children with this diagnosis undergo genetic testing. There are independent risk factors for having metastatic malignant disease, and that includes the SDHB germline mutation, extra-adrenal location, large tumor, and younger age at diagnosis. How do you make the diagnosis? The diagnosis is almost always made on clinical symptomatology and then getting anatomical imaging, but yes, you need anatomical imaging to identify the primary site. Fractionated levels of metanephrine in the urine or plasma are also required, and then functional imaging. MIBG can be used, or other adrenergic functional imaging, such as DOPA scans, so dotatate scans, can be used to look for evidence of metastatic disease. If this tumor metastasizes, it generally goes to lungs, liver, bone, and lymph nodes. Clinical findings, again, are probably something that you could be asked about on the boards. And those patients who have thoracic head and neck, they generally don't have catecholamine release, but could present with nerve palsy or pain. In patients with catecholamine release, there is a classic symptom triad of headaches, diaphoresis, and tachycardia in the setting of hypertension, and this disease should always be considered in children with hypertension of unclear etiology. Hypertension is the most common sign. It can be sustained or paroxysmal, and then headache is present in about 90% of patients. The management is surgical excision. Importantly, we need to consider pre-operative medical management because these patients are at extreme risk for hypertensive crisis under anesthesia. So all patients need to have antihypertensive medications on board, usually for 2 weeks prior to any surgical attempt. And during that period of time and around surgery, we also need to make sure they are well replete intravascularly to avoid hypotension in the operating room. In patients with metastatic disease, the prognosis is actually quite poor, and chemotherapy has been used, cyclophosphamide, vincristine, and dacarbazine. More recently, there have been studies that have shown some activity of using I-131 MIBG for treatment of metastatic disease. And then, interestingly, understanding the molecular features has allowed the implementation of molecularly targeted agents, in particular sunitinib and mTOR inhibitors for the treatment of metastatic disease. Okay, last general category, renal tumors. Problem with that is that it also includes 6 different types of renal tumors. But I think that if you can concentrate on Wilms tumor and a few salient features of the other tumors, you will probably do just fine on your board exam. So Wilms tumor is another embryonal malignancy. It therefore resembles the development of the renal tissue. And the classic pathology has three components: epithelial component, which consists of the glomeruli and tubules, a blastemal component, which is the small round blue cells of the embryonal tumor, and then a stroma component. This tumor, when it does metastasize, goes to lymph nodes, lungs, and liver, and extremely rarely can go to bone. Important feature is something called nephroblastomatosis, which are nephrogenic rests in unilateral or contralateral kidney. So if you just showed a pathologist the slide, they would not be able to tell you if this is Wilms tumor, a big mass, or just changes in the renal tissue. But the presence of those in the tissue means that this patient is at increased risk for recurrence or development of Wilms tumor, and those children need to be surveyed with serial ultrasounds until 8 to 10 years of age. Important about Wilms tumor is about 3/4 of the cases are associated with three main somatic mutations: a WT1, WTX, and WT2. So what WT standing for Wilms tumor. And then in the remaining 25% of cases, there are various other somatic abnormalities. In Wilms tumor 1, germline mutations are present in 10% of those patients, and it's important to always think about associated syndromes in Wilms tumors, and this includes Wagner syndrome, Denny-Drash, and Fraser syndrome for those with tumors that have WT1 mutations. If a patient has bilateral tumor or unilateral tumor with nephrogenic rests on the contralateral side, the thought of considering germline mutation abnormalities in WT1 should be explored. WT2 is also associated with potential for germline mutations. So if your patient's tumor has a WT mutation, you need to be considering Beckwith-Wiedemann or other germline epigenetic changes. And then finally, WTX, which is not associated with germline mutations or predisposition to Wilms tumor. The second most common pediatric renal tumor is something called clear cell sarcoma. As you can see from the pathology, the cells look very different. They generally are in cords or nests of pale staining tumor cells, so not those small blue cells, small round blue cells. Although in the pure blastemal phenotype, it can be confused with Wilms tumor. It has a different metastatic pattern than Wilms tumor, with a much higher propensity for metastasis to the bone, brain, and soft tissue, and has a much worse prognosis than Wilms tumor. Rhabdoid tumor is the third most common renal tumor of childhood. This almost entirely occurs in young children, less than the age of 5, and usually less than 1 year of age. It can coexist with CNS tumors, as you've just heard about, and is associated with lack of INI1 expression, either somatically or a high predilection for germline mutations as well. It also is a very aggressive tumor with a poor prognosis, and it can metastasize to lymph nodes, liver, bone, and brain at the time of diagnosis. Much more rare is something called congenital mesoblastic nephroma, again, generally detected in the first year of life or perinatally. Interestingly, the majority of these patients will present with hypertension, and some have elevated concentrations of calcium. The risk appears to be low for recurrence and generally have local recurrence, and extremely rarely can have metastatic disease with lung metastasis. So the epidemiology, if you put together all renal tumors, they account for 7% of all childhood cancers. As I said, Wilms tumor is the most common, representing 95% of all childhood renal tumors. But in adolescence, that changes, and renal cell carcinoma is the most common tumor in adolescence, tumor of the kidney in adolescence. The epidemiology of Wilms tumor, unlike neuroblastoma, it does have an ethnic predisposition. African Americans have the highest incidence and Asians the lowest. The age is slightly higher than neuroblastoma, but still young, with a median age at diagnosis of 43, and a slight predominance of females for Wilms tumor. It's important to remember that nearly 10% of patients with Wilms tumor will have bilateral disease or have multifocal disease. This slide is out of place, and I apologize, but we'll get to the fact that histology is an important prognostic factor in Wilms tumor. And just remember that anaplasia, the presence of anaplasia, is the poor prognostic factor. So I have several slides on genetic predisposition. I will not go into them because there are multiple syndromes that are associated with Wilms tumor. I try to categorize them into overgrowth syndromes and non-overgrowth syndromes, and the two most common overgrowth syndromes are Beckwith-Wiedemann. I'll be surprised if there's not a question about association of Beckwith-Wiedemann with embryonal tumors on your test. And then less commonly, something called Perelman syndrome. These are other overgrowth syndromes that I won't go into for the sake of time. And then the two most common non-overgrowth syndromes are Wager syndrome, is Wilms, aniridia, GU malformations, and mental retardation, or Denny-Drash, which is severe nephropathy and pseudohermaphrodism. Again, other non-overgrowth syndromes that are there for your review. For renal cell carcinoma, there are also important predisposition syndromes that should be remembered. Von Hippel-Lindau is the most common autosomal dominant condition that has risk for renal cell carcinoma, but also tuberous sclerosis. And then there is a familial renal cell carcinoma, and then leiomyomatosis, and renal cell carcinoma. But von Hippel-Lindau and tuberous sclerosis would be the most common that might be asked about. And then finally, there is a rare cancer of the kidney, renal medullary carcinoma, and its importance in pediatrics is that this is exclusively seen in patients with sickle cell disease or sickle cell trait with a male predominance. And ultimately, 66% of patients can develop renal medullary carcinoma. Okay, prognostic features of renal tumors has to do with stage, size of the tumor, in particular in infants who present with Wilms tumor. Histopathology, as I said, diffuse anaplasia is poor prognosis with a markedly decreased prognosis. And then molecular features of the tumor, which include loss of heterozygosity at chromosome 1p and 17q combined. Patient age, adolescents and young adults have a much worse outcome than younger children, and then children who present with bilateral Wilms tumor have a poor prognosis. How do you make the diagnosis? Many children present with an asymptomatic upper or flank abdominal mass that is noted by the caregiver. However, if you have a toddler who presents with hematuria and hypertension, neuroblastoma, Wilms tumor should be at the highest of your differential diagnosis because of the association with tumor extension into the renal pelvis causing hematuria. Rarely, as I said, in rhabdoid tumors, you can see hypercalcemia or in congenital mesonephromas. Abdominal pain, fever can be seen. These are generally in renal tumors that are having necrosis or intratumor hemorrhage and expansion of the tumor causing these symptoms. I won't go into these, but as we talked about, there's multiple syndromes that are associated with Wilms tumor. Even in children without known germline mutations, there are associated malformations. Aniridia, isolated hemihypertrophy, are things to remember as associated with the development of Wilms tumor. How do you make the diagnosis once you suspect Wilms tumor? Again, anatomic imaging with CT. Ultrasound is often used as well in preparation for surgery to evaluate for intravascular extension. And then metastatic disease and Wilms tumor, chest CT should always be obtained. If you have a concern for a pathologic diagnosis that may have risk for bone metastases, then technetium scans are used. And then in clear cell sarcoma and rhabdoid tumor, most children should have at least an initial brain MRI. These are just some classic radiographs of Wilms tumor. Here you see what is called the claw sign, where normal renal tissue is surrounding the renal mass, and that is pathognomonic radiographically for Wilms tumor. And here you see the presence of bilateral disease, and then finally the presence of metastatic lung disease. There aren't any clear laboratory tests that give you these diagnoses, although bone marrow should be done in patients with clear cell sarcoma, given the potential risk for bone marrow disease. And then an oddity about children with Wilms tumor is that their coagulation studies may be off, because about 5 to 10% of patients with Wilms tumor have reduced von Willebrand's multimer plasma concentrations, which results in alteration of their clotting tests. However, almost all are asymptomatic, and so needing to do coagulation tests prior to surgery is really just dependent on the surgeon's level of concern, and not because we're looking for this entity. Okay, staging. Staging is really based on how the tumor relates to the kidney. So stage 1 are tumors that are completely within the kidney and can be completely resected, and the renal capsule is left intact. Stage 2 are tumors that can be resected, but upon resection, you see that there has been penetration of the renal sinus, the capsule, or into blood vessels, but never truly outside of the renal parenchyma, and all lymph nodes are negative. Stage 3 are tumors that cannot be resected because of invasion into neighboring tissue or positive lymph nodes from lymph node sampling. And then stage 4 is disseminated disease to any of the metastatic places that we discussed. And finally, stage 5 represents bilateral tumor involvement for Wilms tumor, which is about 10% of the cases. The staging in Europe is different. I won't get into it for detail, and I'd be surprised if this is on your test, but in Europe, they give chemotherapy first and then stage the tumor, where in North America, staging is done prior to chemotherapy in almost all cases. Management and treatment. Wilms tumor treatment, and really the treatment of all renal tumors, has really been the success story for pediatric cancers. Starting with surgery alone, the prognosis was dismal. With the advent of the addition of radiation to the tumor site, prognosis improved. And then with the addition of multi-agent chemotherapy, the overall prognosis is actually excellent, especially for patients with Wilms tumor disease. So really the whole progression of what we do for Wilms tumor or renal tumors really depends on the prognostic factors, with the whole hope to give as little therapy as possible, and then increasing the intensity of treatment for those patients who have poor prognostic factors. So the things that are tailored, so in bilateral disease, renal sparing surgery is highly recommended, because otherwise these patients end up with end-stage renal disease from having to take out so much of each kidney. Genomic status is very important, so combined presence of loss of heterozygosity of 16q and 1p generally results in increase of chemotherapy intensity. And then more importantly, both from European studies and North American studies, the rate of response of metastatic disease is a prognostic factor, and so chemotherapy intensity is increased for those patients who have a slower response. And then, as I said, the evidence, the presence of diffuse anaplasia is an extremely poor prognostic factor, and those children require aggressive chemotherapy from the get-go. The role of surgery in general is to have children undergo a complete radical nephrectomy with lymph node sampling with the hope to avoid tumor rupture. All hilar and periaortic lymph nodes are sampled to assess for staging of disease. The contralateral kidney is not explored unless there is something on imaging which represents potential for bilateral disease. Renal sparing surgery is considered not only in bilateral WILMs, but also in those children that have a solitary kidney, a horseshoe kidney, or have a syndrome that may put them at risk for having disease in the remaining kidney. Radiation is really reserved for those children that have more aggressive disease, so stage 3 or 4, presence of anaplasia, and then all children with clear cell sarcoma and rhabdoid tumor. Whole abdominal radiation is required if there's tumor spill at the time of surgical resection. And whole lung irradiation is generally required for lung metastases, although more recent studies have shown that this could be omitted in children who have a complete response of metastatic disease. In renal cell carcinoma, there's really a very limited role for consideration of radiation therapy. And then the role of chemotherapy is really the mainstay of treatment for most renal tumors, with the drugs and the duration dependent on the pathology, the stage, and the tumor genetics. The most common agents are vincristine, actinomycin, and doxorubicin, although cyclophosphamide, etoposide, and carboplatin are also used. Again, for renal cell carcinoma, very limited role for chemotherapy. Pre-surgical chemotherapy should be considered in patients who have bilateral disease to try to minimize how much kidney is resected when the tumor is resected. Again, tumors that present with solitary kidneys, if there is a large tumor thrombus above the level of the hepatic vein or the tumor is felt to be unresectable, then chemotherapy is given prior to attempted resection of the tumor. I'm going to show you two regimens only because you'll hear about them all the time. Regimen EE4A, which is vincristine and actinomycin, generally given for low-stage disease, and then regimen DD4A, which is vincristine, actinomycin, and doxorubicin, generally given for stage 3 and 4. I doubt you're going to have to remember when they're given, but more the general guidelines that the therapy is relatively short, 18 weeks for the very low-stage disease and 24 weeks for the stage 3 and 4 disease, and that radiation is generally given with the DD4A regimen. There are other regimens for more aggressive tumors that I have listed here. And then thanks to a fellow that works at Seattle Children's Hospital, Molly Taylor, who was getting frustrated with what we call our BATs, our best available therapy, she took it upon herself to make these beautiful org charts, and I thought that they would be really helpful for you to be able to just look at visually. If you had a stage 1 tumor, you would generally give EE4A unless there were some unfavorable features of anaplasia. And it goes through each of the stages. I don't think you'll need to know these complete details for the boards, but she did such a beautiful job, I thought I would share it with all of you. Again, stage 3, giving DD4A with radiation, and stage 4, DD4A, and then further intensifying when you have anaplasia or a slow response to treatment. The management of mesoblastic lymphoma is surgery. Adjuvant chemotherapy may benefit in those children who have recurrent disease or metastatic disease, but most of these children are cured with surgery alone. And then finally, the treatment of recurrent Wilms tumor really depends on how the patient was treated up front prior to the recurrence. So if a patient relapses after just getting vincristine and actinomycin, which is about a third of all recurrences, then a second surgical excision, radiation treatment, and alternating between vincristine, doxorubicin, and cyclophosphamide and etoposide is generally the treatment of choice for those tumors. The more high-risk children are those who recur after getting at least 3 agents, or if they had an anaplastic pathologic phenotype. And those children have a very poor prognosis and usually require very aggressive chemotherapy. And there is some data for using autologous transplant with stem cell support for those children who have anaplastic tumors. Complications are related to both the surgery and the chemotherapy. Cardiotoxicity is one of the more common late effects. Secondary malignancies, hepatotoxicity due to dactinomycin and radiation associated hepatotoxicity, and then infertility in those children who get whole abdominal radiation, and then renal dysfunction, especially in patients with stage 5 disease. Musculoskeletal due to radiation, and then secondary malignancies. With that, I'll end this tour through all of those tumors and happy to answer any questions now or by email in the future. Thank you for your attention.